We'll go ahead and get started. Folks will probably be joining as we go, but we do want to be good stewards of everyone's time. This is going to go through, for many of us, our lunchtime, so I want to be good stewards of all of that. My name is Ben Gosson. I want to welcome you today to this webinar. I'm pastor of Trinity Church downtown, and thrilled to be Carol Pine's pastor as she's championed this group and its evolution. Before I introduce our speaker, I want to invite Carol to say just a few words to sort of gather us in today.
Wonderful. Thanks, Ben. My name is Carol Pine, and I am a co-founder of the Interfaith Addiction and Recovery Coalition. And it's a new organization in our community, only about 2 years old. And joining us today are three of our team members, Susan, Pasha, and Michael, and it's great to see them here. We're nonprofit, we're totally volunteer run, and we have a singular mission, and that is to educate and support the faith leaders of all faiths in Savannah and in our nearby communities so that they understand more about addiction and recovery. Here's why we're doing this. Studies really hit me between the eyes when I learned about them. One was conducted by Faith Partners. It's a national organization. In a survey of pastors and faith leaders, they discovered that nearly 1 in 3 people in the pews in faith communities are struggling with a loved one who is dealing with addiction. That is a very high percentage. And here's the other statistic. The National Center on Addiction and Substance Abuse, some of you know it as CASA, did a survey of faith leaders all over the United States about 15 years ago. And of all the faith leaders surveyed, only 12% of them had any training in addiction and recovery in their seminary or religious studies. So as you can see, keeping our faith leaders up to speed on the subject of addiction recovery and understanding what they can do to be of support to congregation members is crucial, especially during a pandemic. Until we had COVID take over our lives, we were offering in-person forums here in Savannah, and we will go back to doing those just as soon as it's safe to do so. But in the meantime, we have been blessed to be able to have virtual educational programs like the one we're doing today. And we could not do it without Hazelden Betty Ford. We have had 3 fabulous programs. Today is our 3rd. The first was the day-long family program. The second was Jerry Moe speaking about the children's program at Hazelden Betty Ford. And today we get to hear from Steve Delisi on adverse childhood experiences. So we are blessed to have colleagues from Hazelden Betty Ford to help us understand this disease better and bring the message to our faith leaders. A couple notes. If you're a faith leader and you would like CEU credits for any of our virtual programs, the family program, Jerry Moe's talk, and Steve's today, please let us know, because we can provide documentation for that. And if you're a guest, if this is the first time you visited us, and you'd like to know more about what we're doing, we would love to put you on our mailing list so you can receive our e-newsletter. So if you would like more information, please reply to the person who sent you the link in the first place, and she will take care of adding you to our master list. And also, if you are in Savannah and you get the Savannah Morning News or you go online, you'll see an article about our work in the March 5th edition of the newspaper. So we're very glad you are here. I am personally so grateful to Ben Gosden, my pastor, and a supporter of what we have been doing from the very beginning, and to Dr. Steve Delisi for being so willing to share his knowledge. So I'll turn it back to Ben. Thanks, everybody.
Thanks, Carol. As you mentioned, today's theme is adverse childhood experiences, and we are thrilled to have Dr. Steve Delisi from Hazelden Betty Ford with us. Steve, we're going to just turn it over to you if you can sort of introduce yourself a little bit, and then you've got a wonderful program in store.
I sure can. Thank you so much, Ben and Carol and Susan, for this invitation. I really am happy to be here with all of you, and hope that our time together will be a mutual learning experience. One of the blessings, if you will, of the Zoom world is the ability to engage with more people from across the country easier than if we had to fly around with each other. I am much more comfortable and prefer to be in person. We're going to talk about human connection, attachment, and touch. And this pandemic has limited that to a degree. But I think we've all adapted to experiencing life together with our little rectangular, I call it my rectangular self. Your little rectangular selves. For those of you who were able to see Jerry Moe's presentation, he's an impossible person to follow. There is no one who speaks with the heart and compassion to compare with Jerry Moe. And I, because of who I am, I will be talking more to the science part of the equation as we speak to addiction. Just as an introduction to myself, I am trained as both a psychiatrist and an addiction medicine physician, double boarded in both of those disciplines. I've spent my 20 years in the field of addiction, most of that as a frontline clinician. 15 years with Hazelden Betty Ford, and my current role is as the medical director for our external initiatives, so training, consultation, and external partnerships with all sorts of organizations across the country. So I am blessed to be able to do these types of events and meet people like yourselves. And again, through the course of this time, I'll spend about 50 minutes speaking to you, and then look to have open question and answer and discussion. And I'm sure that I will learn from the collective wisdom of everyone who is participating today. So again, a really genuine thank you for the invitation. I will share my screen and just ask if somebody can give me a thumbs up that you can hear and see me okay, and you can see now my slides. Yes, excellent. Thank you very much. Really appreciate the feedback. Again, that's one of the downsides of not being there with you in person is just not having that immediate feedback. So we're going to talk about what is the interface between adverse childhood experiences, or what we call the ACEs, childhood adversity trauma, and substance use disorders, or what we more commonly call addiction. And this also overlaps into co-occurring mental health issues. There's overlap for sure. I want to begin by stating that when we talk about the increased risks, that's what it is. It's an increased risk, not a predetermination. And I think that's really important, so that if you know what is true for yourself in terms of what you've experienced in your life, or you know what loved ones in your lives have experienced, what I'm going to be talking about does not mean that then, because of experiences in one's early life, you're destined to have some of the chronic illnesses that I'm going to talk about. It's increased risk that we're going to be speaking of. And one of the reasons that I want to share this information is because human resiliency and our ability to engage and interact with one another can have a moderating effect on this increased risk. So there's a lot of hope also within the presentation that I'm going to be giving you today. This is just, again, a little bit more information about who I am and contact information for those of you who are on this webinar. I always like to start with kind of the roadmap. What are we going to be talking about? Where are we going to be going? And I'm going to expand my view a bit here on my screen. Can I see a show of hands, either your physical hand or a reaction Zoom thumbs up? Who on this call today feels like they really know a lot about adverse childhood experiences and the ACEs studies that have been done across the country? Can I get a thumbs up or a hand? Mary Beth, I see that. Sis, yes. Robert. Okay, so a few of you do. Okay, Dawn, thank you. Excellent. So the beginning of this, for those of you who do have that understanding and knowledge base, it'll be review. I do want to start with defining what the original adverse childhood experiences were and continue to be studied across the country. And these studies go back to the 1990s with the CDC and Kaiser. I'm going to then ask us to expand our understanding of adverse childhood experiences, looking at some of the work that ACEs Connection, that organization, has been doing. We'll understand just how prevalent the adverse childhood experiences are, and as we expand and broaden our understanding, the prevalence becomes even more profound. Then I'm going to shift gears and we'll talk about how those early childhood experiences can impact our health in adulthood. And that's when I'll kind of geek out on some of the biology. I'll warn you right now, that's what I do. But it's important to understand that science is starting to catch up with an understanding of how those experiences affect the very genetics, the very genes that we have, how they are read into the building blocks of our bodies and brains. Then we'll shift and I'll talk about human attachment and the moderating effects that human attachment and positive emotions can have, and how important it is to have a true trauma-informed approach to any engagement that we have. That is not just for clinicians, that is for all of you on this call who have direct impact in the lives of humans that you are working with and interfacing with and sharing life with. Throughout this, I will actually begin with a life history of Kathy, someone that I have worked with, so that we see what this looks like in a human experience. It is a life history that's oriented to my work with her as a clinician, so you'll see that there's a clinical point to it, but then we'll also explore Kathy's adverse childhood experiences and put that into context with the work that we all do. Fair enough? Any immediate questions or concerns before I jump into Kathy's story? And I know that there'll be people monitoring the chat. I always keep at least a half an eye on the chat. And if something really is pressing and you need me to explain something again, you can unmute and call out. But I'm also going to be planning to have time for question and answer at the end. Okay. So let's meet Kathy together. This is a real individual. I've de-identified everything so that we, don't know exactly who Kathy is. But Kathy is a real 29-year-old woman. She first came to me and reported that she had been using multiple substances for the past 15 years. when she came to see me, the main concern that she was reporting was concerns with her opioid and methamphetamine use. And she was both using intravenously with the needle and by smoking it. And her use goes all the way back to her early teens with both opioid medications and benzodiazepines, which are anti-anxiety medicines like Xanax or Klonopin. She also was involved in a drug court. And I share Kathy and her story because so many individuals who need treatment for their disease of addiction first end up in our criminal justice system. And that was true of Kathy. She was pregnant. She was incarcerated because of a possession of fentanyl charge. Fentanyl, I'm sure many of you have heard on the news, is a very strong and potentially lethal opioid medicine, even more potent than heroin. She needed to surrender her 2 young children, aged 7 and 6, and the kids are now with a sister in Ohio. And that was due to the courts because when Kathy was found unresponsive in an apartment with her children present, Kathy had overdosed, but fortunately didn't die. She has used medications to help with addiction, and she's gone to treatment. But what we know of Kathy is that once she leaves a very structured treatment setting, she tends to fade away. And she doesn't return, and she goes off her medications, and she disappears. And we'll talk about that as I share the biology of trauma and addiction later on. She has had 5 years where she did not use drugs or alcohol, but returned to her use after her husband passed away from an overdose. And then shortly thereafter, she was in a car accident and in the hospital received IV morphine. Unfortunately, she didn't share that she had struggled with addiction, and that led to the return to using heroin. And as is so dangerously true across our nation, her drug supply was laced frequently with fentanyl, which made it even the more deadly. That resulted in her being found unresponsive. And she also uses a benzodiazepine. And the combination, I just want to say that the combination of pain medications or heroin and a benzodiazepine like Xanax or Klonopin or Ativan, you might have heard of those medicines. Those are particularly dangerous and are very common across our country. She also has anxiety and depression, and shared with me that she also uses marijuana and alcohol along with that methamphetamine. So perhaps you have someone that you know in your community or in your life that reminds you of Kathy, or you can hold Kathy in mind as now I share some information about adverse childhood experiences. Then we'll learn a little bit more about Kathy's background, and then I'll talk about the biology. So for those of you who know about ACEs, ACEs stands for Adverse Childhood Experiences. This is going to be review. Please bear with me and be patient. The original studies on the adverse childhood experiences began in the mid-1990s. So this is not new information, but we have not done a good job of getting this information out across the country and into our faith communities, our school communities, and our health system communities. The CDC did an initial study. It was a seminal study. Over 17,000 adults participated. And they asked about 10 specific adverse childhood experiences that occurred in the individual's lives before the age of 18. And I'll share what those 10 items are in the next slide. Then they looked and said, what kind of major health issues do the individuals have as they have more and more adverse childhood experiences. And I will also present that information. This quilt of the United States shows that ACEs studies are continuing across the country, and all of the information that I'm going to share has been reproduced and verified time and time again. These are really important issues, and preventing adverse childhood experiences is the most important, or intervening early and helping individuals to have greater resiliency is of paramount importance, especially in the face of the pandemic, as I will speak to in just a moment.
Mm-hmm.
So what are the original 10 adverse childhood experiences? They can be thought of as in 3 different and distinct buckets. Bucket 1 is abuse, experiencing physical, emotional, or sexual abuse prior to the age of 18. Next are things that happened within the home. A mother figure experiencing violence towards the mother. Substance use disorder in the home. A mental health diagnosis in the home. Separation, divorce, loss, and a household member being incarcerated. And then the final 3rd bucket is the bucket of neglect, and that is physical or emotional neglect. So those are the 10 items, and it was just yes, no. Yes, I experienced that during my childhood before the age of 18, or no, I did not. That was the original 3 buckets. This is that information from, and you can see, this is from ACEs Connection. For those of you who want to get more information, I encourage you to go to their website. They have wonderful information, and they also have links to more studies than you would ever want to read on adverse childhood experiences. But what I want to talk about with this slide is I want us to expand our notion of what are adverse childhood experiences. You can see that the tree and the leaves of the tree are mostly those 10 adverse childhood experiences that were most studied. That's what we see easily and above the surface. But look at what are the roots, the bedrock of those adverse childhood experiences. These are the social determinants of health that we often talk about. This is where we see the effects of food insecurity, housing insecurity, employment insecurity, as well as the effects of systemic and institutional racism, historical and generational traumas that are so true for many of the communities across our country, especially as we look at the health inequities in communities such as our African American brothers and sisters and Indigenous brothers and sisters. That's where those roots are, and we'll talk about that as I talk about the science. And then look at number 3. They're pointing out that the environment also has an impact. So the climate crisis, natural disasters, and look here, pandemic. We are all experiencing a global-wide ACEs through this COVID-19 pandemic. It's going to impact the youth to the greatest extent because they are experiencing it through in critically important developmental times. But I know that you all know how much it is affecting all of us. And this, for me, has just amplified the importance of us working together to find ways in which we are helping to support each other and our brothers and sisters across our communities, because the time now is urgent. There are studies that have looked at prior pandemics and prior social disruptions like we are experiencing, and the effects specifically around addiction and mental health are seen a decade out.
Wow.
That's what we know. That's what we know will be our truth if we don't work together to look at how do we make each other and our youth more resilient. Now, this slide helps us to understand that even if we just look at the 10 adverse childhood experiences that the CDC studied, they looked at a population, those 17,000 plus, that was in association with Kaiser Permanente, which is a large health organization and insurer on the West Coast. So of those 17,000, over half, about 51%, were high school graduate, working, had a health insurance. So they were middle to upper middle class. It was not the general population. It was a subset slice, and almost 2/3 of that slice had at least one adverse childhood experiences. Over 20% had 3 or more. And if we look at the bottom right where it says 4 or more, that's the level at which that risk of chronic disease starts to really spike up. And what we see in that original study is 15% of women and almost 10% of men had 4 or more adverse childhood experiences. What about subpopulations? In a study of women in treatment for addiction, 83% of them had 4 or more adverse childhood experiences, 83%. And if we look at those who are justice involved, who find themselves like Kathy in the court system, their incidence of 4 or more adverse childhood experiences across both genders, youth or adult, is at least 4 or 5 times higher than what the CDC reported. So prevalence, take home point, this one's easy, very common. Very common, which is why my call to all of us is to, as we sit down with ourselves, let me back up. All of us who come to this call, we've had a childhood, right? We've all been through childhood. We come through childhood with our wounds. And so this time together is also for us to talk about and reflect upon what we have in our lives. Again, not with a fatalistic, oh my goodness, look at my ACEs score, I'm going to have all of these health risks. No, but a recognition and acknowledgement and an awareness, and then a response towards resiliency, hope, and faith. So part of this is, what can you all do for your communities, but also what can you do for yourself? What can you do for your loved ones? And what can you do for your colleagues? Let's turn back to Kathy. Kathy grew up in a family similar to the original CDC study. It's, again, one of the reasons I would pick Kathy's story. Both her parents were prescribed pain medication. So opioids are the pain medications that you hear about. And both of them misused their pain medications. They did have issues with an addiction to their pain medications. Her parents also divorced when Kathy was 12, due in part to her father being violent towards mother. Mother also was on benzodiazepine anti-anxiety medicine. She was on Xanax and also misused that medication. Kathy's mother had a mental health diagnosis. She had severe panic disorder. And Kathy used Kathy's use of both the pain medicines and the anti-anxiety medicines, they began in her teens when her mother began offering her a pill, in quotes, here or there, just to help me relax. That's such important information, because what we hear from Kathy is that her young teenage brain is now being affected by potent pain medicines and anti-anxiety medicines. And what else is Kathy learning from her mom? If I feel something, I take something. If I'm feeling something, I need to numb it and make it go away. That's so important in helping to us to understand how people come to be using and having the addictions that they have. She also remembers neglect. Her mother would leave her home alone. Mother would also have times where she would pass out due to the combination of medications. Kathy also was a victim of sexual abuse between the ages of 4 and 10 by an older maternal cousin. And unfortunately, when she tried to confide in her mother about this abuse, Mom ended up blaming Kathy for the abuse. And ultimately that led to Kathy being kicked out of the home. And about from age 16 on, Kathy was living on her own and surviving in any way, shape, or form that she could. So if we ask, what is Kathy's score? I want to just bring this into the real world. Someone like Kathy, where is she with those traditional? She is a 7. And that's before we think about what some of her bedrock social determinants of health might also speak to. And we can also talk about the fact that she has kids age 6 and 7. They're also experiencing their own adverse childhood experiences, aren't they? It brings up the importance of how do we work together to help Kathy, because in helping Kathy, we do early intervention or prevention for the next generation. Does that make sense to people? So when you're doing the work of supporting the parents and the families in your congregations and your communities, that's actively early intervening and or preventing the next generation with adverse childhood experience, which have a significant impact, which we'll now pivot to. You remember that Kathy is sitting at a 7, please. So what do we know? Back with the seminal Centers for Disease Control study, if you had 4 or more, remember I said that 4 or more was the real spike in risk. Not that you're going to have these disorders, but that there's increased risk. 4.5 times higher, that's 450% higher risk of depression, 200 to 400% increase in alcohol use disorder, and a 7 times higher risk for illicit drug use disorder. Look at the suicide risk, 12 times higher. That's 1,200% higher risk of suicide. And it's not just mental health and addiction, 2.5 times higher risk of chronic lung disease, 2.5 times higher liver disease. At the 7 or more ACEs, like Kathy was sitting at, 3-fold higher risk of lung cancer, 3.5, almost 4 times higher risk of heart disease. And look at that, 20-year reduction in life expectancy. With this data, the former president of the American Academy of Pediatrics, Dr. Block, once said that adverse childhood experiences represent one of the most critical, under-recognized, and under-addressed health crises in America. And I absolutely agree with Dr. Block. Is this information, does it stand the test of time? Yes. Here's a much more recent study from the Child Abuse and Neglect Journal looking at unpacking the impact of adverse childhood experiences on adult mental health from just a few years ago. What you're seeing here is a stepwise increase. As you increase adverse childhood experiences from 1 to 2 to 3 to 4 to 5, you see that overall there's a clear stepwise increase for heavy to moderate alcohol use, for illicit drug use, for depression, clear stepwise, and look at suicide. Look at that dramatics. And these were suicide attempts, not suicidal ideation, but suicidal behaviors as you increase the trauma history. When you get to 6 or more in this study that was done more recently, the risk went up to 24.36 times increase. This starts to help us to understand, if we say that adverse childhood experiences are prevalent, and if we include the bedrock social determinants of health and some of the true social inequities that are tied to historical and generational traumas, and then we add environmental trauma, we can start to understand the increases in what's called the deaths of despair across this country. And again, so that we're not just talking about negative, there are things that can shift that trajectory, but we have to know what we're looking for and then how to best engage. Again, those of you who have had experience with adverse childhood experiences and have learned about them, you've probably seen this was the original, what was called the ACEs pyramid. And you can see down at the base are the adverse childhood experiences, and adverse childhood experiences cause disruption in neurodevelopment, the development of the nervous system. I'm going to touch upon that when I geek out, so just be ready, it's coming. Directly then cause social, emotional, and cognitive impairments in individuals that lead to both adoption of health risk behavior taking, not by choice, but how we are programmed and wired through that neurodevelopment. Choice is not the issue here. Also, the changes in how our bodies develop with early trauma and adversity directly relate to increased disease and disability, leading to early death. Now, the ACEs literature has been updated to do just what I've already talked about. So I'm not going to belabor this, but I want you to show you people are catching on. The social conditions, the local content, and generational and historical trauma, they're really the base of this pyramid. We were missing that for well over a decade. And now we're recognizing that, again, is where we need to be focusing attention, because from a primary prevention, early intervention, and reducing inequities, that base has to be part of what we talk about together. At the peak of this pyramid is early death. I told you that it's as much as 20-year reduction in life expectancy. But what you're hearing in the news is about the deaths of despair. And specifically, the deaths of despair are most often defined as those deaths related to suicide, intentional self-harm, drug overdose, and alcohol-related deaths. And over the past decade, we have seen these deaths marching upwards like no prior decade before. And while drug overdoses in 2018 seemed to level out, and we were all excited that maybe we were getting on top of that epidemic, we were not. And 2019 showed an increase. And when you look at the first 6 months, that's what's been looked at thus far. When you look at the first 6 months into 2020 with COVID-19 and the pandemic, the epidemic sitting inside of a pandemic, we're seeing anywhere from 30 to 40% increases in deaths, overdose deaths, which would be expected. And I hope that after this time together, you'll understand a little bit about how that is linked as we talk about the interface between the trauma and addiction and the importance of human attachment and connection, and how we're disconnected with that. This next slide, I'm going to just it's going to appear right here in the white. It's going to be a map of the United States, and it's going to play itself through. You can kind of focus in on Georgia, but also get a gestalt of the U.S. The darker the states get, the higher the incidence of suicide, and it's going from 2012 to 2019. And you'll see some go darker blue and then come back to lighter blue, but on average, you will see that the United States is sadly becoming darker blue, meaning more suicide deaths. So here we go. Come on, play. So in Georgia now it's looping back, but in Georgia at its darkest it was in 2019. The most recent year of data for your state showed a bump to almost 15 per 100,000 passing away from suicide. Okay, here comes some of the science now. I'm going to try to connect some dots here. I think that most of us, especially given the work that you all do and the work that I do, I feel fundamentally that I'm often preaching to the choir here, no pun intended, versus nature in terms of understanding how people become who they are, but it's nurture plus nature. It's our genes plus our experiences and our environment. But science was lagging behind. We didn't have a good way of explaining how does that happen. And if we're going to expand it to those historical and generational traumas, how does that track from one generation to another? That brings us into the field of epigenetics. Again, with a show of either physical hands or Zoom reaction hands, who's heard of epigenetics? Epigenetics. Sis, Wendy, and then some naughty Carol, you have? Yep. So epigenetics. So there's genetics, and so that's the study of looking at what are the genes that we get, half from our biological mother and half from our biological father. Those are our genes. That's our DNA, the building, the blueprint for creating the building blocks of our body and our brains. What epigenetics is the study of how do things in our environment, our experiences, or things that we ingest, how do they affect how our genes are read into those building blocks? So I'm not going to go through all of these mechanisms. That would be horrific, and I'm sure people's eyes would glaze over. What you need to know is, see this rectangle in the middle bottom. You see a little pink band of DNA. That's a gene that's in our DNA. But in this state, it's all coiled up, and it can't be read into a building block of either our brain or our body. It's hidden, so to speak, so it's not read. If, however, something happens in the environment that is connected to this gene, it opens that up, and you can see how this pink band is now open, and the mechanisms by which cells read genes can now go on. And a whole different protein, a whole different building block will be produced. The analogy that I think helps to kind of drill this home is, let's say I gave all of you a well-written paragraph to read. And it was well-written, so when you read it, I said, hey, what's the message that this paragraph is saying? If it's a well-written paragraph, you'd all read it and you'd come back and it would be you'd all share a very similar message. Do we agree on that? If it's well-written and you all read the same paragraph, the same message? Now, what if I split this group into 3 different groups? And I said to the first group, take that paragraph, but I want you to read every other word. I want you to skip the other words, and I just only want you to read every other word. Group 2, you read every third word. And group 3, I want you to read every word, but I want you to read it backwards, right to left. Would everybody agree that those would be 3 different messages that you would come back with? Anybody disagree? If you disagree, unmute and make your point. But I do think it would be 3 different messages. That's epigenetics. The environment tells the cells how to read the genes. It's the same paragraph with the same words in the same order, but the instructions are what are different. And it can have very different impacts on who and what we become. What are some examples? I gave just 4 examples that speak predominantly to addiction and mental health for us to understand. Is this real life? What do we really know about epigenetic changes and how it then leads to what we see as an adult? First one is, if you have high degree of adverse childhood experiences or childhood trauma or chronic trauma, the genes for inflammation change so that your body has chronic active inflammation. At baseline, you will have a higher degree, well, an increased risk. Again, human bodies are different. Human bodies have resiliency, but there's an increased risk that your inflammation system will be on go and you'll have chronic inflammation. And chronic inflammation can lead to high blood pressure, but could also lead to major depression when you have a chronic inflammation of the central nervous system. There is also increased activity of your stress response. So individuals who have had adversity in childhood, trauma in childhood, their stress hormones are genetically hyperactive. They're primed to respond. Why? Largely because the individual who's experienced trauma needs to be scanning the environment at all times to ensure that they do not get harmed again. And so they are in fight, flight, or freeze mode much more readily and chronically. Someone like Kathy, remember I told you that Kathy would do okay when she was in that structured setting, but when she was out in the community, she often would disappear from treatment. Part of that disappearing may have been getting triggered in terms of her trauma and then fleeing and running away as a survival mechanism. There's also, we've heard so much about the opioid crisis and chronic pain and how prevalent chronic pain is. There's as many people with chronic pain in the United States as with addiction. Both are at about 20 million people across the country. And I don't think that that's by any coincidence. When you think about, again, that epigenetics, childhood traumas, chronic trauma, adversity, increased genes for pain sensitivity. And so things that are less painful become more painful for individuals because their whole pain system is hypersensitive. And then the final is what we're going to be talking about in just a couple slides. And that is that there are brain changes in the areas of the brain that are responsible for what we call substance use disorders or addiction. Individuals who have that, again, it's a risk. It doesn't mean that it's predestined, but we know that individuals with increased trauma will have changes in the deep area of the brain, which is called the limbic system. We're going to learn about that in just a moment. That's where emotion is, and memory is, and reward. Our reward pathway is there. And that is changed biologically with these epigenetic changes. And the very front part of the brain, that's what's most highly developed in humans. The very front part of the brain is kind of our executive computer. It's where judgment, insight, problem solving, perspective, choice, and our personality comes in impulse control is in the front part of the brain. And individuals who have had these traumas, they can have increased risk of a delay in the development of that very front part of the brain, which is important in regulating our reward area and our emotions. And that'll really make sense in just a moment. So I'm going to ask, for those of you who know how to use a chat function, I'm just going to take 1 minute on this. Can I ask you to say, as you're sitting there today, when you think of someone who has a substance use disorder or an addiction, what's most true for you? Do you see that addiction as a chronic recurring disease of the brain? But individuals with addiction have genuine choice about whether to seek or use substances? Or is it a brain disease where people have practically no choice? Or is it primarily a failure of self-control, or primarily reflects personality flaw or a moral lapse? By just putting in a letter, A, B, C, or D, what do people think? An A? Thanks, Allison. Thanks for breaking the ice. B, thank you very much, Anna. A, Jane. Anyone else think A? Okay, so A and B, and that's what's been really gratifying is that is where people are sitting. I think we have been doing a better job of understanding addiction as something that does have the biology that I'm about to share with you on the very next slide. And then in terms of choice, I'm going to make the point that in the midst of active addiction, and in those who have this genetic or epigenetic predisposition, choice as we know and think of it really is not part of what is true for most individuals with addiction. Now, B is not untrue as someone moves forward in their road to recovery and healing, because part of the healing is the functioning of that very front part of the brain and choice coming back online. So thank you for participating. I really appreciate that. So here's the brain. And I'm going to walk through this, and hopefully it will drive home some of what you've already learned, and will help us to understand Kathy. So first thing that you need to know is that oftentimes there are three major reasons why someone would be using an addictive substance initially. Initially, what's reinforcing? And when I first talk with someone who's saying that they're struggling with a substance, alcohol or a drug, I'll ask them, I'll say to a Kathy, tell me those first few times that you used that substance. Tell me the story of what it did and what you experienced. And then I just stop and I listen, and I always think about listening for one or more of the three next themes. One is the theme of euphoria. Here will be the story of the person saying, oh, the first few times that I used, I felt great. I felt amazing. I felt better than I'd ever felt in my life. I had more energy and could do everything. I was high, right? All of that is what was reinforcing for them in that moment was it made them feel great. We call that euphoria. But that's not always true of individuals. Sometimes what they tell me is the first few times that I used, I didn't hurt for the first time in so long. Or I felt numb and it just felt good to not feel anything. Or I felt comfortable in my own skin for the first time in my life. I could sit in me for the first time in my life. or I felt normal. Have we not always heard that? It made me feel normal. All of those are speaking to the theme of reducing some type of pain, either a physical pain or a psychic emotional pain. And it numbs it. And alcohol and many of the drugs that are addictive do a good job initially of numbing pain. Now, often when talking about biology of addiction, that we stop there. But there's one more that I think is critically important. I've always felt it is important, but now in the era of the pandemic, I think it is of extreme importance, and that is human attachment. Here, the theme in the story will be that when I first used, I felt an overwhelming sense of belonging. When I used initially, I felt connected in a way that I'd never felt before. Or I felt a warmth come over my entire body, or I felt literally hugged or embraced when I used. All of those are communicating that that individual had a triggering and an activation of the human attachment system deep in the brain. And that system is complicated, but superimposed over our reward pathway, that area that's activated by things that are important to our survival that I will look and talk about in just a moment. And the reason that they're overlapping is I believe we as humans are hardwired and designed to be in fellowship, to be with each other for our very survival. It from a pure biological survival on Earth, we're not the strongest, fastest, best adapted species on planet Earth. If we did life totally independent from one another, we would be extinct. But what makes humans able to adapt across the globe is we do life together. And I believe that that's why this biology of human attachment is superimposed upon the reward pathway. So let me show you the reward pathway, and then we'll talk about attachment again. The reward pathway, a lot of people say that the reward pathway, which is hardwired into each and every one of us, we all have this reward pathway. Oftentimes people say that's the pleasure center. I think that that is wrong. I do not like talking about it as the pleasure center. Sometimes rewards are pleasurable, but not necessarily. What they are is important to our well-being and our survival. That's what this limbic reward system is hardwired and scanning the environment. What just happened that is most important to our well-being and our survival? It's programmed to pick up things that are natural rewards, like food, water, fellowship, love, physical intimacy. I'll show you the dopamine that's released when we are physically intimate with another human being. That's important to the survival of our species. So it's a natural reward. And when that happens, this part of the brain says, hey, what that just happened, that loving fellowship relationship right there, that spiritual experience, that moving event with family, that exercise, that's something that we need to reproduce. The problem is that dopamine, which is released there, is the signal for important, pay attention, important, pay attention. And the more and faster dopamine is released right here in the center of the brain, more and faster means more important. So let's look at this graph. When you woke up, your brain was releasing about 50 units of dopamine just to get out of bed and get moving. If you had breakfast, it went up to 60 or 70 to tell the brain, hey, that food, that's important. Physical intimacy, it's a part of human experience, 100 to 150 units. Love, 100 to 150, that intense emotion drives dopamine. But what does heroin do? 800 units. And methamphetamine, 1,200 units. So this middle part of the brain sees 800 and 1200 and says, most important thing to survival. That's the most important thing to survival. Human touch, human attachment is also releasing dopamine by activating the opioid system. That system that is activated by our brain's own, what we call the endorphins. And when we are with each other, we release endorphins, and especially with touch, we release endorphins. There's also, I'm sure most of you have heard of oxytocin, the love hormone, that hormone that's released when a woman gives birth and is breastfeeding, and mom's brain is bathed in oxytocin, and baby's brain is bathed in oxytocin. When you are gazing into the eyes of another human being and feeling the love and the trust, that releases oxytocin. And if there's further sense of attachment, and if there is touch, human touch, working synergistically with that love hormone is our brain's endorphins, our own opioids, how the brain was designed. And it is released, and we feel even more connection. And that is healing. That's the healing that comes when we connect one human with another human. When you are supporting human connection, forging human relationships within your congregations and your communities, that is biologically a healing force, and it acts in this area of the brain. The problem is that if the individual is getting that opioid system activated from outside, it's activated so much more that it overwhelms everything else. Now, true, and if you use an addictive substance, it's going to just explode the dopamine, then why doesn't everyone who uses alcohol or a drug, why don't we all develop an addiction? And that brings in this front part of the brain, the very front part of the brain. That part says to the midbrain, the limbic system, it says, whoa, 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 wait a minute, chill out, you reward center, chill out, you emotion center. Let's keep perspective. There is no way that that drug is the most important thing to your survival. That's a false signal. And you've got a choice as to whether you're going to use it or not, based upon, is that truly the most important thing to your survival, and is it consistent with your value system? And the last time that you used, it did not go well for you. So we're not going to use again. That's what a fully functional frontal lobe does. That's choice. That's what this part of the brain does. However, if you remember, if someone has had early childhood adversity, has had chronic trauma, they're at risk of this part of the front part of the brain developing slower. So it's not as online. And that then leaves this limbic response saying more faster dopamine, that's the most important thing to survival. That then is the primary signal. And in active addiction, when the person is actively using, this control from front to midbrain is not working. There is not that logical choice and judgment. There's not as much control of our impulses. There's not as much control of our emotions. As someone continues to use over and over and over again, what happens to the dopamine? The dopamine goes way down, and we experience more and more and more and more anxiety and stress. We experience the withdrawal symptoms. And then what happens is one of the more insidious parts of the disease of addiction. There is a role reversal where these limbic emotion and survival, basic instinctual survival signals starts to drive the front part of the brain, where we have the problem solving. And these are when people are talking about cravings and the, in quotes, insanity of the mind. I can't get my mind off. When am I going to use next? Who am I going to use next with? Where am I going to use next? How am I going to use next? All of those are the limbic system, this reward and emotion centers driving that front part of the brain. It's not that there's no function here. It's just that it doesn't have control. And in fact, there's an insidious role reversal during active disease. That's the importance of treatment, healing, time away from the substances, to bring this front part of the brain back online to then quiet and regulate the middle part of the brain as it is wired and designed to do. So that's my biological story of the disease of addiction. One of the things that often comes up is, well, okay, Steve, that's great, but how do I know if I'm struggling with some disconnect with the front part of the brain, or a loved one is, or someone, again, you've got someone in your congregation and you're sitting down with them and they're sharing their story like Kathy. How do we know that Kathy might have that disconnect? These are what you're going to see in that time with Kathy. These are stigmatizing. Like, I would never say to Kathy, wow, you're very argumentative and thin-skinned, and whoa, aren't you self-centered, right? I want to be very clear. That's why it's in blue, bold-faced, and underlined. This is not what I would say to anyone like Kathy, but I'm sharing it with you because when you're in the room with Kathy, you can get triggered and have some visceral responses, especially if we're coming into that space with our own traumas. It can trigger us. When we see Kathy showing this profound inability to objectively assess herself, and chronically poor judgment, and an inability to learn from experience, like everybody else in Kathy's life knows exactly what's going to happen when Kathy picks up again, except for Kathy. It's infuriating. Before I understood this to be true, I had a whole big head of curly hair. I pulled it all out in frustration working with Kathy because I expected Kathy to come along, get along, right? She's not able to initially. We've got to help her and create that structure and support around her until her front part of the brain comes back online. She's going to be difficult to have attending and focusing, and she's going to be bored and then disappear and not come. And so you might start working with a Kathy and feel like the counseling work is going really well. She's showing up, and then suddenly you're seeing her on Sundays and for midweek activities, and then she just disappears. That's partly because, again, she may have been triggered with trauma and she's gone into flee mode, or she just doesn't have that wherewithal to logically get to things over and over again reliably. You also, and this is where we have to check ourselves, we have to check our own reactions, because Kathy might be argumentative. She may have an explanation of why all the suggestions you're giving are not good suggestions, and be very, very thin-skinned, prone to be offended and disorganized. Those are symptoms of Kathy's trauma and addiction. They are not her being a difficult person. They are not a personality character flaw. They are symptoms, just like someone's blood pressure is a symptom of their high blood pressure. And these are symptoms we all can use to better understand where Kathy's in our lives are. As Kathy gets the care and treatment that she needs, you will see these things coming back, and she will have these capacities, and that you can share with her and say, this too is healing, and it is wonderful. That's the promise of working and helping people into recovery, is because within recovery, they can actually be doing better than they were before in their lives, if we help them to get the help that they need. Does that make sense to people? It also is an opportunity, again, think about being self-aware and what's true of you. And are you struggling with any of this? And are you struggling or have struggled with addiction? Or is there someone in your family or a colleague, someone that you know who needs that support and care? Because this is very, very treatable. This slide just speaks to we're getting to towards the end. Just a few more slides. Trauma, having a trauma-informed approach is not just for clinicians. For all of you watching today, being aware and recognizing how prevalent trauma is, especially as we expand the notion of trauma and we include what I've talked to today, and that we recognize that there's a biology, yes, there's a psychology and a sociology and a spirituality to everything that I'm talking about. I firmly believe that we are bio-psychosocial spiritual beings, but those are not separate silos. They're all part of a whole, and they interact with each other all the time. And so having that recognition and understanding is important, because then you can meet a Kathy where she's at and not get upset and angry or feel frustrated or like, I don't even know what to do, because there's practical things that you can do. And that's where you respond in human connection and human attachment and focus on Kathy's strengths and focus on promoting positive emotions. Why do we do that? This is a very biological slide. Ignore the biology and listen to my words. When you are sitting and you are gazing into the eyes of another and you feel that human connection, know that your brain and that other's brain are mirroring each other, both in neural activity and that love hormone. Know that that is true. Dr. Barbara Fredrickson, her most recent book, Love 2.0, speaks to, she's a wonderful researcher in the realm of love and positive emotions. Recommend her to all of you. At the same time, it's a positive feedback loop, because as oxytocin is bathed in our brains, it promotes more attachment and trust. So it's a positive loop. Those of you who have dogs at home, I want to share, when you are gazing into the eyes of your dog and the dog is gazing back at you, both brains are releasing oxytocin in that moment too. It's part of the biology of the human canine attachment that is a particular attachment. Also, you see here touch. That I already said, touch releases beta endorphins. You hear about people saying, I got my endorphins running. Beta endorphins is that endorphin. And when we touch and we embrace, that is released. Think about the child on the playground who falls and skins their knee, right? They're screaming bloody murder. It's as if the limb has been lost. If there's a healthy attachment to a parental figure, what does that child do? That child makes a beeline and runs to the parent. And if that relationship is healthy, what does the parent do? Embraces the child. And in that moment, both brains are releasing oxytocin, both brains are releasing beta endorphins, and there's a sense of well-being. There's a sense that this is important to survival, and pain also decreases. That's how we're wired. That's the, in quotes, normal biology. And when we have early childhood traumas and adversity, we'll have a lower baseline endorphin level. We will also have lower dopamine level. So what happens when that individual uses alcohol or opioids or a methamphetamine? By the way, all of which increase our activity of opioids in the brain. And what is ravaging our nation? Alcohol, opioids, and methamphetamine. I think it has everything to do with this attachment piece to our human survival. And when that is low and they experience it for the first time, it's even more reinforcing, because they're starting from a lower point and then it's going higher. And so it's even more reinforcing. They're at greater risk of developing an addiction. And low beta endorphin will promote us to seek out one another. Again, we are truly designed to be in fellowship for most of us. Not everybody, but for most of human, we're wired for each other. And so low, someone coming out of a trauma childhood, they will be wired to seek out others. But they are also wired now to be distrustful. to be more afraid, to be more fight or flee. And that works against that. And then what happens when they first use something like heroin? Now their opioid is highly active. They have no desire and no drive to seek out others. They're just fine. I've had patients say, if I'm using, I don't need other people. That's part of the isolating nature of the disease of addiction. The other part is the horror of internalized stigma and shame. What can faith leaders do? This is not rocket science. This is, though, how all of us can have a very dramatic effect. First is what you are doing right now. Increasing the awareness through education and a willingness to engage in conversations about addiction and childhood adversity and trauma. And I include there also the co-occurring mental health disorders. Having a real appetite to learning and engaging the congregation and the community in dialogue and discussion. Providing opportunities to families, parents, and children, all three, to help support them directly within your faith community, and looking for ways in which your faith community and congregation can support initiatives that are going on in the larger community. We're all in this together. We can't do it alone. Continue the wonderful work of connecting people and forging real relationships. That gets directly at that attachment. That's healing, and that is a biological and psychological and spiritual treatment, if you will. Promote a culture of acceptance for people struggling with addiction or other mental health issues. You are welcome here, who you are. And then, of course, reducing stigma and shame and increasing faith and hope. All of you can do all of this directly with what you are doing already. The only shift would be doing it with an intentionality around that awareness of trauma, addiction, and co-occurring mental health. It's not changing what you do, it's changing the intention of how you link it to what we've been talking about this morning. Societally, and this is really my last slide, and then we'll go to the Q&A. What more can we do? Economic support for families, especially again in areas where there is profound inequities. Pre and postnatal care, parenting skills, especially positive parenting, family-friendly workplaces, improved mental health and addiction treatment for parents and awareness in schools, early detection and behavioral mindfulness and resiliency strategies for our children, and then again, promote human attachment. And with that, I will stop and we can go to question and answer. I went 10 minutes longer than I had hoped. My apologies for that, but I will stay on a little bit longer if we have more questions, because I really want now to open it up for everybody. I'm going to stop my share, and I thank you so much for your engagement and paying attention the whole time. Thank you.
All right, Steve, we've got 2 or 3 questions here in the comments. I'll let you kind of take them in whatever order you want to take them.
Absolutely. So I'm seeing the question about the sand tray play-based therapy. Absolutely, that can be of help without question. Again, doing so with the intention to look for ways to help the kids interact and feel that connection with each other. Nothing, I don't believe anything is the substitute for being in the same space and for that human touch. I have been fortunate enough to have received my second COVID vaccine now 3 weeks ago. Our church here, I live in a very small town of only 600, so we have one church that we all attend, and it's a very old building built in 1872. So it doesn't just have bad ventilation, it has no ventilation. So we have not been worshiping together. It's all been online and recorded. But for Advent and Lent, we've bundled up and we've stood outside the front door of the church with 2 big fire pits and had 20-minute outdoor services just so that we could see each other 6 feet apart. We'd have to kind of alternate who was closest to the fire pits in the middle of the winter. We had our masks on. But I bring this up because this Sunday was one of those services. I had received the vaccine, and one of our friends from church, her son-in-law died suddenly in his sleep 3 days after his 50th birthday, leaving a wife and 2 young children. And she was there, and we locked on, that the half face, only the eyes, but we saw in each other's eyes, again, that human connection. There was no question. Oxytocin, again, going to be reductionistic with the biology. Oxytocin is surging. And so after the service, she made a beeline, and we're not to do this. We're asked to just kind of dissipate and go our separate ways to be safe. But she made a beeline to me, and we will let everyone else leave. And then she needed time to talk and just be. And what she really needed was to be hugged. There half a face was going to be doing in terms of connection and attachment. And so I felt, knowing who I am and who she is, we would have hugged without the vaccine. But it was doubly nice to feel that safety in being able to do that. So I don't think anything that we do is going to be fully substitutionary, but we are a resilient species, and our rectangles, we have a connection. I can assure you, the times that you've been nodding when I see smiles, that gives me a little flush, and that's a moment of connection. So absolutely be doing your sand table and looking for ways in which those kids can also, through the sand table, express things that they cannot otherwise express. That too is resilience that you're doing. So I love that. So thank you for that. What suggestions do you have for worship, for how worship time can be used to help address addictions, ACEs, and other matters? For me, that is a time that you can weave in awareness, right? Worship time is not time for therapy, but worship time is a time to provide information and to provide awareness, and to be communicating very clearly that culture of awareness, recognition, and acceptance. And that can be part of the worship time as you lead the worship. Also, there are the times outside of worship for support groups that you can help to support at your congregation, allowing mutual help groups to come together and do fellowship with one another on your grounds, again, when we have the ability to do that. So hope that was helpful. Thank you for your positive feedback. I hope that this is going to be, you sign off and say, well, that was 90 minutes worth spending, and not getting that 90 minutes back. So I do hope that this was helpful. Yes, Carol, I agree with you. Faith leaders are absolute. you are the leaders and the trusted individuals within your communities. I mean, our Pastor Joel and our Pastor Hannah, they've been the lifeblood of our congregation through the online, and they are most definitely the thread that is weaving this quilt that's now a Zoom quilt together. That's not to say that it's all on your shoulders, but you absolutely play pivotal, important roles, and are in a position where, with that awareness and sharing a genuine comfort in discussing these issues at a congressional level, that communicates at a deep level that sense of acceptance, without question. I will have to add, again, please know, and I say this to you as I say it to all of the other healing individuals in today's world, and you most definitely are healers. We need to also, again, be paying attention to our self-care and our self-healing needs, and again, the healing, care, and support for each other. More important now than ever. I will share a sorry note that a colleague here in Minnesota, a physician, mother, wonderful human being, took her life on March 5th. And that is the fourth physician or resident in the Twin Cities that I know about just since COVID. So, and I know that there are countless others that I don't hear about. Please know that you're not doing this alone. Know that there are places for your health and healing, and then help and support each other, please.
All right.
I don't know if I've...
Go ahead.
Okay. No, I just was going to say, I don't know if I've missed another question in the chat, or if there's those that want to speak and share a comment, share your own wisdom on what we've talked about, or ask another question. Thank you.
I just want to thank you for this learning experience. It has been absolutely wonderful. Thank you.
Oh, thank you, Jacqueline. That means the world to me. Thank you. Thank you.
And we'll do one final call for questions. If anyone has one, feel free to unmute and speak up.
I have a general question.
Yes, Andrew.
First of all, thank you for the presentation. Very informative and helpful. Just a general recommendation or advice on this. A lot of these online psychiatric psychologists websites are producing, having all these conglomerates of mental health professionals. What's your opinion of those systems? Are they viable resources for communities where there aren't a lot of psychiatrists or psychologists?
So are you specifically, let me just make sure that I'm understanding the question. Are you talking about the online therapy and treatment offerings that are now popping
Yes.
up? So like kind of the telehealth and telemedicine?
And
yes.
Specifically one like BetterHelp and those type of websites and
yeah.
stuff. Yes, sir.
Yes. So one size does not fit all. I can't comment in a generality. There are some that have very dubious information and are offering services that are quite frankly not evidence-based and are more profit-driven. That I see as the minority. There are some very good options, and we have actually found that the ability to provide care and support via remote has been far more positive than we thought. I'm an old school doc, right? I'm a dinosaur. So it's in the office, person in front of me, and so I was very leery about this whole but we have found it to be something that is certainly better than nothing. has been an opportunity in this space, and I think I will say to you, will be here to stay, because there are so many communities that don't have a Hazel and Betty Ford sitting in the backyard. And so being able to engage, I just would say that have some caution and do some research in terms of the background and who's doing what. But it's also been interesting. There are patients who very much prefer doing it remotely. They like the ability to wake up, roll out of bed, stay in their pajamas, and go in the kitchen and do treatment at their kitchen table, and not have to deal with all the logistics, especially if you're trying to deal with the logistics of transportation and you don't have your own transportation, or you've got young kids at home who are doing remote school, for Pete's sake. How do you get to treatment? How do you go to a group or see someone like me? So that remote can be a good option. Thanks for the question.
Well, it is 12:31, and so as we said at the beginning, we want to be good stewards of everyone's time, and so we thank you for first of all, Steve, absolutely, as everyone has already done. Thank you for such an informative presentation, and we thank all of you for your attendance today. Carol, are there any final instructions on maybe when the next webinar is, or anything you want to add?
What I would like to add is that this presentation will be on YouTube at our Interfaith Addiction and Recovery Coalition site. So if you'd like to review it again, or if you'd like a colleague or a friend to see it, it will be up, I'm sure, in the next day or so. So I want you to know that. And any of you who would like to be on our mailing list for what the next program we're going to plan, we'd love to hear from you. And as I said earlier, just reply to the notice you got about Steve's talk today, and the person who receives your info will make sure we get you on the mailing list. But we're delighted that you all came, and particularly grateful to Dr. Delisi. I'm amazed at the amount of energy required to present like this, and I am in awe. So thank you.
You are very welcome. It is truly, truly my great honor to participate with you. You are all doing truly the most important work that there is. And thank you for everything that you are doing to help our brothers and sisters out there. Thank you.
Thank you, Steve.
All righty. Thank y'all for your time, and we'll be back with another presentation soon.
All right. Thank you, folks.
Bye, all.